Good evening to everyone and welcome to today's session. We welcome all our online students, Dr. Deva, Vinod, Neena, etc. etc. Now, today we will finish few leftover topics in endocrinology for us to start neurology from tomorrow. So, hyperparathyroidism and hypercalcemia is one of the favorite topics of the examiner, which we need to be very clear about. Now, if you look at the parathyroid hormone, it is a 84 amino acid hormone. It is a pre-pro hormone which is produced by the chief cells of the parathyroid glands, and whenever the ionized calcium levels in the serum fall down, that is a stimulation for the parathormone levels to basically increase. I hope that Neena, Deva, everybody, you have answered the quiz, so that after a few topics are over, we will have a live interactive discussion of the quiz. So, it is that specific G protein coupled calcium sensing receptors on the plasma membrane of the parathyroid cells which will be able to detect constantly how much is the ionic calcium levels in our body, and accordingly the parathormone is released. So, what are the functions of parathormone? One of the favorite MCQ, any entrance you go. Osteoclastic resorption of the bone will occur. That's the reason. Where do you get secondary hyperparathyroidism, doctor? If there is any vitamin D deficiency, and because of that if there is a hypocalcemia, that stimulates the parathormone release, and that released parathormone will resorb the bones and that lead to brown tumors in the bone, that resorption of the bone. So there is an osteoclastic resorption of the bone mediated by the parathormone. Then it will increase the absorption of the calcium from the intestine. It will hasten the formation of 125 dihydroxy vitamin D by increasing the 1-alpha hydroxylase levels in the kidney. It will increase the renal tubular reabsorption of the calcium, and it will lead to, one side it will increase the absorption of calcium, so that more calcium is reabsorbed back from the tubular fluid back into the body. But what is the effect of it on phosphate? Lot of people do this, lot of people don't know this fact. It will lead to reabsorption of the calcium, but it will lead to increased excretion of phosphate into the urine. So phosphaturia is the effect of the excessive parathormone, is what you have to be very clear about. So one side it will reabsorb calcium, other side it will make us lose the phosphate. And it is the membrane receptors and adenylate cyclase as the secondary messenger, leading to cyclic AMP formation as a secondary messenger, is the important mechanism of the parathormone. That's a short introduction about the parathormone. Now, hypercalcemia. One of the common questions in the entrance, can you decrease the voice slightly? Decrease. Slightly. Now, what are the causes of hypercalcemia? Any excessive PTH. It can be primary hyperparathyroidism, or it can be ectopic PTH secretion, or it can be secondary hyperparathyroidism in a hypocalcemic state, just like vitamin D deficiency. But remember, in primary hyperparathyroidism, excess parathormone will lead to hypercalcemia. Tertiary hyperparathyroidism, there will be hypercalcemia. But secondary hyperparathyroidism, there will be no hypercalcemia. Why? This is a very important point. Frequently asked question in the exam. When do you call secondary hyperparathyroidism? First, there is a hypocalcemia which stimulates the PTH release, and the PTH in turn will cause the resorption of the bone and drag the calcium out of the bones into the serum. And that bone resorption, whatever the calcium that moved into the plasma, it will make the low calcium levels reach normal but not high. So, primary hyperparathyroidism and tertiary hyperparathyroidism basically will lead to hypercalcemia. But secondary hyperparathyroidism may hypocalcemia becomes normocalcemia, it won't become hypercalcemia. So that is what you have to be very clear about. Similarly, any ectopic PTH, for example, you take squamous cell carcinoma in the bronchogenic carcinomas in the lung, it can produce ectopic PTH. Then certain malignant disorders like myeloma. What is the cause in multiple myeloma for the hypercalcemia? Because myeloma will lead to osteoclast activating factor, which will lead to the resorption of the bone and lead to the development of the hypercalcemia. Then any excessive vitamin D like action, sarcoidosis and TB. Why that is hypercalcemia, doctor? Sarcoidosis is an inflammatory state. And whenever there is inflammation, chronic inflammation, macrophages will release a substance which has a vitamin D like activity. That macrophage released vitamin D like activity containing substance will lead to development of hypercalcemia in case of the sarcoidosis. Similarly, milk alkali syndrome is another important condition. So she says we can't hear. I think why is there any problem in the broadcast? No. You can just check whether there is any problem in the broadcast, because some of the students are punching, they are unable to see, or is there any problem in their local bandwidth? Alright. Then Edison thyrotoxicosis. There are two endocrine conditions which can lead to development of hypercalcemia. Then drugs leading to hypercalcemia. Favorite question of the examiner. So thiazides, vitamin D analogues, lithium, vitamin A. Any of them can lead to the development of hypercalcemia. And any long-term immobility. And there is an entity called familial hypocalciuric hypercalcemia. That is, kidneys will be secreting less amount of calcium into urine, and that lead to development of the hypercalcemia called familial hypocalciuric hypercalcemia is what you have to basically remember. So now, what are the main causes and pathophysiology of hypercalcemia? The hypercalcemia. Primary hyperparathyroidism and malignancies, they are the most common cause. Then hyperparathyroidism can be primary, secondary or tertiary. Primary means what? It is the parathyroid adenoma, generally single adenoma is the one which is responsible for the development of hypercalcemia. Then multiple parathyroid glands may be involved in multiple endocrine neoplasia type 1 and 2A, which also can be associated with hypercalcemia. There is an entity called hypercalcemia, hyperparathyroidism, jaw tumor syndrome, which is a familial cause where parathyroid carcinoma and maxillary and mandibular tumors occur together, is called as hyperparathyroidism, jaw tumor syndrome. Now, let us discuss about primary hyperparathyroidism. Typically, any chromosomal rearrangements in the 52 regulatory area of the parathyroid hormone gene can be responsible for primary hyperparathyroidism, underlying genetic basis. Then what is meant by secondary hyperparathyroidism? Whenever there is any low calcium, Then, for example, somebody is not eating well and there is a hypocalcemia, or somebody is having vitamin D deficiency and hypocalcemia. Any hypocalcemia can stimulate the production of the parathormone as a compensatory mechanism, which lead to the development of what is called as secondary hyperparathyroidism. Then, what is meant by tertiary hyperparathyroidism? Suppose for a long period of time, if a person is having persistently secondary hyperparathyroidism, after some period of time, parathyroid glands become autonomous. When they typically become autonomous, then what we get is basically called as tertiary hyperparathyroidism. And if you look at the tertiary hyperparathyroidism as such, calcium levels will increase and phosphate level also will increase, and at this stage they require parathyroidectomy. Otherwise, those autonomous parathyroid glands continue to hyperfunction and keep on producing the parathormone. Now, what are the important symptoms and signs of the hypercalcemic state? If hypercalcemia is mild, it is often asymptomatic and nothing need to be worried if it is less than 3 millimoles per liter. Suppose if it is more severe, then it starts producing the symptoms. So there can be renal coli, there will be polyuria. Why polyuria will be there in hypercalcemia, doctor? Because hypercalcemia will have an effect on the renal tubules, and it will typically cause a resistance to the action of antidiuretic hormone. So hypercalcemia will produce a state of nephrogenic diabetes insipidus like situation, and that lead to, if the ADH cannot work, what will happen? There is no antidiuresis. If there is no antidiuresis, then there is diuresis. Hence there is polyuria. So polyuria can be one of the important clinical presenting feature of the hypercalcemia, is what you have to basically remember. Then primary hyperparathyroidism, if you take in the people who have 100 people who have renal calculi, 5% people will be having primary hyperparathyroidism. Primary hyperparathyroidism is commonly because of adenoma. Typically adenoma of the parathyroid gland, single adenoma of the parathyroid gland, and they need to ultimately get operated. So that's the reason patients who have renal calculi, you should evaluate for a possibility whether there is any underlying primary hyperparathyroidism responsible for their hypercalcemia, is what I want to underscore to all of you. Now, if you look at the other features, there can be bone pain. Hyperparathyroidism mainly affects the cortical bone, and that will have a local destructive effect. So bone cysts, brown tumors, they are all the important features of hyperparathyroidism. There can be abdominal pain, chondrocalcinosis and ectopic calcification which can occur, and there can be calcification in the cornea. If there is a corneal calcification, it always signifies a long-standing hypercalcemia, is what you have to basically remember. Then if there is hypercalcemia in a patient of malignancy, is it any indicator of the severity of the malignancy? Definitely. Any malignant disease in which you discovered hypercalcemia means advanced stage of the malignancy, is what need to be basically remembered. Now, which cancers are notorious to lead to the development of hypercalcemia? Bronchogenic carcinoma, breast cancer, myeloma, esophageal, thyroid, prostate, lymphoma, renal cell carcinoma with its osteolytic nature. They are all the ones which can lead to development of hypercalcemia. And most of the times, it is the parathyroid hormone like peptide production which is the underlying cause. And If the patient has got severe hypercalcemia, more than 3 millimoles per liter, generally the underlying etiology will be either a malignant disease or hyperparathyroidism, or patient is on vitamin D therapy, can also be responsible for severe hypercalcemia. Only 3 causes which lead to very significant and severe hypercalcemia, which you need to remember. Now, how will you evaluate and investigate a patient who is having hyperparathyroidism? You need to do the serum PTH levels. Just find out whether Dr. Fahima, she is able to have a proper broadcast or not. Earlier she had a little problem, no? Find out whether her problem got solved or not. Sometimes if your local connection is little slow, you may have a difficulty with the broadcast, but ideally you need to have a good connection. Let us pray for it. Now, if you look at primary hyperparathyroidism, typically patients will have hypercalcemia with hypophosphatemia. Why hypophosphatemia? Because that excess PTH produced by the parathyroid adenoma will lead to phosphaturia, and that lead to development of hypophosphatemia. So, hypercalcemia with hypophosphatemia with an elevated PTH levels is equal to primary hyperparathyroidism. So, whenever you have this combination, hypophosphatemia, hypercalcemia with the elevated PTH, all such patients, even if they are asymptomatic hypercalcemic guys, you need to evaluate them. Then, often these patients will have hyperchloremic metabolic acidosis, patients with PTH, high PTH. Then we evaluate 24-hour urinary calcium, or we do calcium creatinine ratio, especially with young patients who have elevation of PTH. Why? Because one of the rare causes of the hypercalcemia which we discussed was familial hypocalciuric hypercalcemia. Due to the low calcium going into urine, there is a high calcium in the plasma. So how do you discover that? You need to do 24-hour urinary calcium or calcium creatinine ratio, then you will be knowing whether the calcium is excreted into the urine normally or not. So, young patient with high PTH with only modest elevation of calcium and PTH, you should evaluate for familial hypocalciuric hypercalcemia. Then if there is a severe parathyroid bone disease, then that can lead to elevation of the alkaline phosphatase. If it is very severe, but generally the principle is hypercalcemia lead to osteolysis, not osteoblastic response. That's the reason you don't expect high alkaline phosphatase in case of hyperparathyroidism. So that is the reason, doctor, elevated serum alkaline phosphatase is found only in severe parathyroid disease, but otherwise it suggests an alternative cause of the hypercalcemia other than hyperparathyroidism is what need to be remembered. Then we do protein electrophoresis to know whether multiple myeloma is the underlying cause of the hypercalcemia. And never forget, thyroid dysfunction also can lead to hypercalcemia. So, you should always exclude hyperthyroidism by assessment of the TSH in a patient of hypercalcemia. Then, Addison's is another endocrine cause which you should not forget, which can lead to hypercalcemia. So, that is the reason you need to do the cortisol assessment and if required ACTH test in order to know whether there is any Addison's disease. Then serum angiotensin converting enzyme levels need to be evaluated in order to identify whether sarcoidosis is responsible for hypercalcemia. And if there is sarcoidosis or vitamin D mediated hypercalcemia, or if malignancy is leading to hypercalcemia, all those hypercalcemic states, in all these three hypercalcemic states, you can suppress that hypercalcemia by giving a hydrocortisone injection. So, this one of the favorite MCQ in the tomorrow's exam. What are the steroid suppressible hypercalcemic states? You must be very clear. Typically sarcoidosis, vitamin D mediated hypercalcemia, and some malignancies associated hypercalcemia. These are the three important scenarios where steroid, if you administer like hydrocortisone, it is capable of suppressing the hypercalcemia, is what I want to once more underscore to all of you. Now, if you do imaging, what do you see? Abdominal X-rays will show renal calculi and nephrocalcinosis. X-rays will show subperiosteal erosions in the middle and terminal phalanges. If you do bone density scan, DXA, then it is very, very useful, especially in asymptomatic patients with hyperparathyroidism. Suppose if you are planning the conservative management, see how much the bone got eroded by the hyperparathyroidism. Suppose if already there is osteopenia when you have done the bone density scan, then you should not go ahead with conservative management. You need to surgically manage. But bone density scan is showing that osteopenia is not severe enough. Then you can conservatively manage without surgery. So that is the role of the bone density scan, which you need to remember. Then we do the imaging, and remember that direct exploration of an adenoma is much better than that of the imaging techniques in order to identify. Nowadays we have minimally invasive surgery, right, which can be able to identify, I mean, you can be able to resect the parathyroid glands much more easily laparoscopically. So we use the MRI as the imaging modality to identify the adenoma leading to the hyperparathyroidism. We do technetium sestamebe radioisotope scanning in order to detect the parathyroid adenoma. And how do you treat if it is primary hyperparathyroidism is a very important question. Now, we have new therapeutic agents that will specifically target the calcium sensing receptors in the parathyroid gland. They are called cinacalcet, and typically they are of a great value in the patients who have parathyroid carcinoma, or even in dialysis patients with chronic renal failure with severe secondary hyperparathyroidism. For them, the cinacalcet like agents are helpful, which basically will target the calcium sensing receptors. Now, a very important point frequently asked in the entrance: what are the indications for surgery in a case of primary hyperparathyroidism? When do you want to put your knife and operate is an important question which you have to be very clear. If there are renal stones, or if there is an impaired renal function, yes, indication for surgery. If there is a bone involvement with a marked reduction of the bone density, when you have done the bone density scanning, dual absorption spectrophotometry, DEXA scan, if the bone density is markedly reduced, indication for surgery of that parathyroid gland. Then a young patient below 50 years with a previous episode of acute hypercalcemia, yes, indication for surgery, you have to be very, very clear about. Now, you have an acute episode of severe hypercalcemia. How do you want to clinically manage such a patient is one of the very, very important fundamental question in the entrance exam. So, if there is a acute hypercalcemia, what did we say? How does it present? Hypercalcemia will act on the renal tubule and it has got a diabetes insipidus like effect. anti-ADH effect. Na? So they lose a lot of water in the form of polyuria. So they are dehydrated guys. That's the reason you need to treat the dehydration, and if the serum calcium is more than 3 and sometimes above 5 millimoles per liter, you need to basically give an emergent treatment, and you need to rehydrate at least 4 to 6 liters of 0.9% normal saline on day 1 and another 3 to 4 liters for several days thereafter you need to do, and you need to put a central venous pressure monitoring. Then intravenous biphosphonates are a very important drug which are considered to be treatment of choice for the management of acute hypercalcemia of the malignancy, or if the underlying etiology is unknown, there also there is a role for intravenous biphosphonates. Famidronate is the one which is a preferable agent, and if you give it within 24 to 72 hours, the calcium levels will come into control. Prednisolone, typically whenever there is a steroid suppressible hypercalcemic etiology, then you can give prednisolone. Then we can give calcitonin, but it is a short-lived action, and we give oral phosphate, but oral phosphate can produce diarrhea. Phosphate can chelate the calcium, na? So that is one effect of phosphate. But if you give oral phosphate, it can produce diarrhea, is what you have to basically remember. So that is all the story of how do we manage a case of acute hypercalcemia. Now doctor, before we say goodbye to the topic of hypercalcemia and hyperparathyroidism, you have to be very clear about this concept called familial hypocalciuric hypercalcemia. Number one, what is the inheritance pattern of it? Autosomal dominant. It is usually asymptomatic, and though the patient has hypercalcemia, still there is an increased reabsorption of the calcium in their renal tubules. The tendency for increased reabsorption of the calcium in the tubules is the one responsible for their hypercalcemia. If the calcium is more reabsorbed from the tubular fluid, what will happen? Calcium won't enter into urine. Hence there is a hypocalciuria there and hypercalcemia in the blood. So why is the tendency in them? Typically, there is loss of function mutations is the genetic basis. Long arm of the chromosome 3 is very, very important for deciding calcium ion sensing receptors in the renal, in the kidney and parathyroid gland. So they are abnormal. Constantly they will be thinking that body doesn't have calcium, body require more calcium, is a kind of a wrong sense they go into. So there is more and more reabsorption of calcium in spite of hypercalcemia, and that lead to development of hypocalciuric hypercalcemia, which is an example of the loss of function mutation, is what you have to basically remember. Most of the times for them there is no need of parathyroidectomy, and how do you differentiate it from that of the primary hyperparathyroidism? Typically you need to calculate the urinary levels of the calcium and the calcium creatinine ratio in the urine and blood. By that you will discover, oh, this hypercalcemia is because of hypocalciuria. So what will happen in primary hyperparathyroidism? Primary hyperparathyroidism guys have got high calcium levels, but that high calcium will also enter into urine, so urinary calcium also is high. Whereas in the people who have hypocalciuric hypercalcemia, they have high calcium in the plasma but a low calcium in the urine. That's how you basically differentiate. So this is all the story of hypercalcemia, doctor. At least 5 to 6 points in this favorite questions of the examiner. Steroid suppressible causes are what? Most common cause of the primary hyperparathyroidism is what? etc., etc. How do you differentiate familial from that of primary hyperparathyroidism? These are all the issues you need to strongly ingrain yourself. General medicine is a subject of logic, reasoning, and of course a compendium of facts which you need to be very, very clear about. So doctor, before we go to the next topic, I think I like to wake you, the guys who are in a sleepy mood at the end of a hypercalcemic bout. Shall we take up the quiz? Very good. So where is the quiz? Yeah. Before that, I like to introduce to you one very important website that I have discovered, which will help all our students to come to one common place. For example, about some 100 people enrolled for this present course. Out of the 100 people, how many am I able to see here? Around 14-15 people, because exam is there in another 2-3 days in Andhra Pradesh. Whoever has enrolled may not be there at this point. So the 100 students or 200 students who have enrolled, different parts of the day they will be going through the video library and reviewing the lectures asynchronously. Whoever has time will come to this evening class and attend the session. Very good. Everything is fine, sir. But the notes that we are generating, every day we create new content, new quizzes, etc., etc. So we, just like Facebook, this site called Edmodo, EDMODO, edmodo.com is a wonderful opportunity for the teachers, students and student community to be together until the exams. So we will create one username and password for you as a student to enroll into, get into this Edmodo. We will give a telephone to you, a ring to you, and then send you the username passwords that we generated for this course, which you have joined, which is going to run for a long stretch of 145 days. So when you enter into this, you will have a discussion forum where you can ask your classmates, you can exchange your phone number, email ID with them, and then you can exchange some materials with them, and you can also, suppose today's lecture, if it is there, we will upload it into the Edmodo beforehand so that you can download it from the library of the Edmodo. And if you have any questions to ask to the teacher, you can post it onto the wall so that the teacher will, whenever the teacher gets time to go through the account, he can see what all the questions and queries students have and he can instantly answer. And you will have lots and lots of quizzes and polls we will be hosting in this. So that is the new wonderful way where tweeting, discussion forums, downloadable libraries and resources, and a student community is all can be integrated into one common platform of Edmodo. So we have created edmodo.com/online-MBBS, one community. So you can, we will give you we already pre-subscribe you and send you the username password of that, and you start using this so that you won't worry that notes has not come or notes is not emailed to you. There is no need of specially emailing to you. It will be available in the library. You can simply download it. So that way we can be able to do. Then one more attempt we want to do is Google Hangouts is a wonderful way where teachers, students can sit together, discuss a topic in a more informal way, in a more casual way. Google Hangouts. We will also one of the evenings experiment with a Google Hangout. If you have a webcam at your place, you can be part of the Hangout, and in turn the Hangout get broadcasted. So we can do all those things. So the modern learning on an online platform is more interesting, unlike the earlier passive learning, going to live classes, sitting in a crowd, and Saturday, Sunday liquidating ourselves. There is no need of that with the mobile learning. So let us take up the quiz. Where do we have quiz? Timing, no timing, no? Huh? What we should keep? Correct? You want to take a backup and start? 2 minutes, doctor. We will take a backup of this video and then we will restart.